Hari Om, 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 Hari Om. Namaste, Hari Om. July 17 July 2018. Welcome to all of you to the International CME Lipidology Atherothrombosis update being held at the Jnana Sanjeevini Diabetes Hospital Medical Center in Bangalore, India. So let us begin today's proceedings with a small prayer. Namaste. Saraswati Namastubhyam Varade Kamarupini Vidyarambam Karishyami Siddhir Bhavatu Mesada. O Goddess of Knowledge, Saraswati, the giver of boons, the embodiment of fulfilling the wishes, my salutations to you. I shall begin my education, and may there be always accomplishment and success for me. Vakratunda Mahakaya, Surya Koti Samaprabha, Nirvignam Kurume Deva, Sarvakaryeshu Sarvada. I meditate on Sri Ganesh, who has a curved trunk, large body, and who has the brilliance of a million suns. O Lord, please make all my works free of obstacles always. Thank you. Now we move on to the first webcast from the National Lipid Association on the important topic of resistant hypertension. Ladies and gentlemen, kindly enjoy and enrich this presentation on resistant hypertension. Thank you.
Well, thank you very much. I appreciate that introduction. So I'm going to talk specifically about resistant hypertension, which is obviously a subset of those 100 million folks who have hypertension in our country. And what I'll argue is that this group of individuals, we have a specific definition for how to identify people with resistant hypertension and a very specific treatment algorithm that is not just about adding medications, but about a comprehensive approach to workup and to management. Here are my disclosures. And I think it's important to recognize that in each field of medicine, we sort of have sacred texts. And in the arena of resistant hypertension, I would say this is one of those sacred texts. This is the 2008 scientific statement from the American Heart Association that the first author was David Calhoun. This is currently undergoing revision, and we should have an update to this scientific statement within the next few months. But I don't anticipate that there are going to be major changes because we haven't seen tremendous changes in the science behind resistant hypertension. And I think importantly, the Guidelines Committee, the 2017 ACCHA Guidelines Committee, has essentially re-endorsed these guidelines, that scientific statement, I should say, with a couple of just very modest modifications. So I'm going to sort of walk through this guideline, which is, as I say, very similar to the 2008 scientific statement that I referenced earlier. So this will be essentially our outline. This is the outline from that scientific statement and from our current guidelines section on resistant hypertension. And we'll sort of take each of these in turn. I do think that the first, always important to start in the first place, and confirming the diagnosis of treatment resistance with the updated definition, I think is quite important. I run a resistant hypertension clinic in Northern Nevada, and I'm still quite surprised by the number of folks who carry the diagnosis of resistant hypertension and are referred to our center for having resistant hypertension who actually don't meet the criteria for resistant hypertension. So here's the definition. I'll focus on the definition from the ACC-AHA guidelines that Dr. Taylor just presented to you. The definition is blood pressure that is not controlled, and based upon those new guidelines, that would be not controlled to a level of less than 130/80, despite use of 3 medications, ideally one of which is a diuretic, and all of which are used at reasonable or near optimal doses. There's also an additional definition where we talk sometimes about controlled resistant hypertension. A patient who is controlled but requires 4 or more medicines is also considered to have resistant hypertension. They have controlled resistant hypertension. So keeping that definition in mind, I think, is very important. And when we just think globally about, or in our country, when we think more comprehensively about the problem of poorly controlled hypertension, which you saw in that last slide, Dr. Taylor, has now increased numerically based upon these new guidelines. We have tens of millions of folks whose blood pressure is not controlled. And I think it's important to point out that the minority of those patients actually have resistant hypertension. This is from a nice publication by Dr. Brett Egan from a few years ago, and does use a different definition of blood pressure control. But what you see is that it's actually a relatively small minority of people who qualify for resistant hypertension. What we really, from a public health standpoint, have a larger problem with is undertreated or unrecognized hypertension. So if I put on my public health hat and I had to organize what we should spend the most of our resources on, it is first identifying patients with hypertension. Second, making sure that we are treating them with 1, 2, 3 medications plus lifestyle medicine, plus lifestyle changes. And then really focusing our efforts on that smaller group of individuals who will turn out to have resistant hypertension. So confirming that definition is important. The second thing we look to is to exclude pseudo-resistance. Pseudo-resistance, I don't know if that's a term that you've heard before or not heard before, but I would define it as it is exactly what it sounds like. It is folks who look like they are resistant, look like their blood pressure is not controlled, but actually their blood pressure is controlled if we were to look at it carefully enough, or they don't meet the definition for other reasons. So the main types of pseudo-resistance, and I think these are all very prevalent, are inaccurate blood pressure measurement. I can tell you that I, quote unquote, cure a lot of resistant hypertension in our center by simply using appropriate cuff size. So proper blood pressure measurement will often lead to lower blood pressures, as Dr. Taylor just suggested. Poor adherence is a very important cause of pseudo-resistance. We may have prescribed 3, 4, 5 medications. Patient may be taking those inconsistently. And in some of our patients in our resistant hypertension clinic, I actually hope they don't go home after seeing me and actually take all of their medicines because oftentimes adherence is a big, big problem. And then the concept of white coat hypertension. Patients whose blood pressure may be poorly controlled in the office, but if their blood pressure is measured carefully outside of the office, do have reasonable blood pressure control. And this is one very nice study, I think, that comes from a single center in Spain that took a group of individuals who had apparently treatment-resistant hypertension. Their blood pressure remained elevated in the office despite 3 medications, and they did ambulatory blood pressure monitoring on all of them. And what they found was over a third of them actually had well-controlled blood pressure when it was measured on ambulatory blood pressure monitoring. So certainly a big part of the workup of the patient with apparent treatment-resistant hypertension is getting good quality out-of-office blood pressure readings, perhaps first starting with home readings, but if those home readings suggest white coat hypertension or white coat resistance, perhaps following up with ambulatory blood pressure monitoring would be appropriate. Once we have identified treatment resistance, excluded pseudo-resistance, the next thing we're asked to think about is to identify and reverse contributing lifestyle factors. There are obviously quite a few of these that we could talk about. For the purposes of time, though, I just wanted to talk a bit about sodium restriction. As I'll speak to in a moment, we think that one of the major pathogenic reasons that patients are resistant to medication is volume overload and resistance to diuretics. And in many people who have more mild to moderate hypertension, as Dr. Taylor showed you, reduction in sodium leads to a fairly modest reduction in blood pressure. But in these patients with resistant hypertension, we can see very significant reductions in blood pressure with sodium restriction. Of course, to do these type of studies is not easy, just like it's not easy to get people to reduce their sodium in clinical practice. These studies, the study that's cited here was actually done by hospitalizing patients and putting them on a low sodium diet, which is one of the only ways to be effective in reaching these low levels of sodium intake in many of our patients. Nonetheless, I think this is something we should always be working towards in our patients, is a reduction in sodium. In addition to lifestyle factors, there may be other things that patients are doing to keep their blood pressure elevated despite your best efforts. These include a number of different interfering substances that they may be taking. And there is a long list of potential interfering substances that I won't spend the time to go through each of them individually, but certainly I think the top couple deserve mention and are very frequently found in the patients who are referred to our center. Non-steroidal anti-inflammatory drugs are notorious for causing increases in blood pressure in certain individuals, and getting patients down to at least the lowest effective dose of those medications, if not substituting another means of controlling their pain syndrome, I think is important. Alcohol, also a very important issue, as are illicit drugs and some of the other drugs that may be prescribed to people in different clinical scenarios. So going through a list of medications with patients and taking a very careful social history is quite important. And oftentimes we make use of clinical pharmacists in our program also to take a look at these patients and try to minimize some of these interfering substances. Next on our algorithm would be to screen and potentially consider treatment of secondary or contributing causes of hypertension. And I would say that I tend to divide these into those that we commonly see in resistant hypertension and those that are a little bit less common. And in general, I think that we should be looking for, or at least thinking about, the common etiologies of secondary or contributing causes of hypertension in most patients who have resistant hypertension. So that doesn't mean that we necessarily need to be doing, for example, sleep studies in all of these patients, but at least taking a good sleep history, asking about snoring and daytime somnolence, looking for chronic kidney disease as a cause of, not just a result of, resistant hypertension. Screening for primary aldosteronism with a serum aldo and a plasma renin, I think for most of these patients seems reasonable. Whether or not to look for renal artery stenosis in all of these patients is a matter of some debate, but I think it's something to at least consider. Could that be contributing to your patient's blood pressure problem? And obviously thyroid disease, very common and easy to screen for. Some of the less common causes, secondary causes of hypertension, I think we screen for less often, and we usually reserve the screening for those conditions to patients who have a clinical clue that one of those conditions may be present. For example, decreased pulses in the legs in a young person, we might want to consider about aortic coarctation, and somebody who has the physical features consistent with Cushing's, we'd screen for it in that setting. So at least a thoughtful approach to thinking about secondary causes in patients with resistant hypertension. And then finally, only after we have done those other steps in the algorithm, confirmed treatment resistance, excluded pseudo-resistance, identifying lifestyle factors, thinking about secondary cause, decreasing interfering substances, then and only then do we start thinking about changing their pharmacologic or adding to their pharmacologic regimen. And I specifically suggested that we both rationalize and intensify the management of these patients. I think that very often these patients have been through many times years, if not decades, of going from one provider to the next. Perhaps they have had perceived intolerance to medications some years ago. And oftentimes they end up coming to us with rather unusual regimens through no fault of their own or their providers. But I think when we identify somebody with resistant hypertension, going back to first principles and really think about building a rational treatment regimen for them. Sometimes by starting over, I think is just as important as intensifying their medication. So the concept is not just, I'm not just going to continually add medicines. I want to think about what they're already on and whether what they're on currently makes sense before I add to it. So just building upon what Dr. Taylor said, I always like to think about building the foundations of antihypertensive therapy. And this is sometimes referred to as ACD therapy. An ACE inhibitor or angiotensin receptor blocker, a calcium channel blocker, and a diuretic, usually a thiazide-type diuretic, as the foundation of therapy for the vast majority of patients with hypertension who can tolerate it. So usually trying to get back to that foundation is where I start, and it's recommended that we start in terms of treatment of resistant hypertension. Every building needs a good foundation. So really kind of getting back to that foundation is important. If we do have a patient who is on that foundation, sorry, if I could just go back a slide. Thank you. The next step is usually to maximize diuretic therapy. As I mentioned earlier, we think that in the majority of these patients, there is a certain component of volume retention that is leading to the resistance. And when you think about it, when we are giving, many of these patients are on a number of different vasodilators, and we're essentially shunting blood and perfusion away from a kidney that's usually, oftentimes been damaged, has subtle damage from years of uncontrolled hypertension. And so that kidney will avidly hold on to sodium. So usually our next step is to maximize diuretic therapy. Our guidelines recommend consideration of chlorthalidone rather than hydrochlorothiazide as a more potent on milligram per milligram basis thiazide type diuretic. It also has a longer duration of action than hydrochlorothiazide. So certainly is an option for patients with more difficult to control hypertension. In patients with significant chronic kidney disease, and sort of the number that we often think about is a GFR of less than 30, it may be reasonable to switch from a thiazide-type diuretic to a loop diuretic for better blood pressure control. And then the next step generally in most patients who have resistant hypertension would be to add a mineralocorticoid receptor antagonist like spironolactone, or if that's not tolerated, perhaps eplerenone. I do think it's important, the caveat at the bottom of this slide is very important. Many of these patients do have underlying renal dysfunction. And when we do add diuretic therapy, which is going to be beneficial for kidney protection in the long run by lowering these patients' blood pressure, in the short run, we do have to be careful with watching for azotemia and for problems with renal dysfunction. So I just wanted to show a little bit of data that supports the use of spironolactone in these patients. I actually find this data to be very compelling, although it's sort of a post hoc analysis. This comes from the ASCOT study, which was a very large blood pressure study done quite a few years ago that compared two different treatment strategies for the early treatment of high blood pressure. But the algorithm for that study suggested that if patients were not controlled on 3 drugs, that the 4th drug, as we're advocating in our guidelines, that 4th drug be spironolactone. And this is post hoc analysis of a pretty good number of patients, 1,400 patients who actually received spironolactone in that study, and shows their blood pressures before they received spironolactone versus after they receive spironolactone. As you can see, a very significant reduction in blood pressure of about 20 millimeters systolic in this, once again, uncontrolled, non-randomized data. But I think is very compelling and has led to some better designed clinical trials that have tried to prospectively look at the effect of adding spironolactone in these patients. This is the fairly recently published Pathways 2 study, which looked at patients with resistant hypertension on a good foundation of therapy, and then looked at adding spironolactone versus adding a beta blocker or a peripheral alpha blocker in these patients, and did find that spironolactone was the most effective of these potential add-on medications. Once again, if we look at home systolic blood pressure at the bottom of this slide, about a 12 or 13 millimeter reduction in blood pressure with the addition of what is an inexpensive and generally well-tolerated agent. So in terms of our guidelines, what is the next step after we've sort of added spironolactone and optimized that 4-drug regimen? Our guidelines generally call for referral to a clinical hypertension specialist, which after this talk, I hope that we all will be in this audience. I do urge all of you to take a look at becoming a clinical hypertension specialist. There is a pathway to doing so that you can certainly investigate. But the things that I think we need to think about after that, we have this patient who potentially is on 4 drugs now, an ACE inhibitor, an angiotensin receptor blocker, a calcium channel blocker, a diuretic, and a mineralocorticoid receptor antagonist. Our choice of 5th and 6th drug becomes much more difficult and is not guided by very much data. I can tell you that personally, I think that peripheral alpha blockers and beta blockers and perhaps using our dihydropyridine calcium channel blockers and non-dihydropyridine calcium channel blockers together are some reasonable options to think about for the next drug. But I think that we are, once we get to 5 and 6 medicines, we're really sometimes into the art of medicine as much as the science. I do think there are a couple of points to take into account. If you wouldn't mind going back a slide for me. There are a couple of points to keep in mind when adding other medications. There is some limited data, mostly comes from a single center in Spain, that if we move at least one agent in a multi-drug regimen to nighttime dosing, we can see better blood pressure control and actually some suggestion that improvement in clinical cardiovascular events. I also think that there's at least we should consider declaring victory and going home in some of these patients. I think it's important to recognize that although we do have a blood pressure target of less than 130/80 in the vast majority of these patients, that doesn't mean that every single patient needs to be treated to less than 130/80. And unlike lipid-lowering therapy, where we have seen that it appears that specifically looking at LDL as a target, if we continually lower LDL cholesterol, we see continued benefits and very little in terms of side effects. We do know that blood pressure is a hemodynamic variable, not just a risk factor. And lowering blood pressure with 5 or 6 medications certainly may lead to adverse effects in some of our patients. So I think a careful risk-benefit analysis of exactly how many medications we want to use in each patient and when we should consider perhaps a blood pressure in the 140s in some of these patients to be reasonable control for that individual is, I think, an open question that we need to continually look at. So I did want to just spend the last couple of moments just talking a little bit about where this field is going. This is the equation for blood pressure hemodynamics. The 3 main contributors to blood pressure you see here are renal volume retention, renin-angiotensin system activation, and sympathetic nervous system activation. And we've talked a lot about blocking the renin-angiotensin system and volume, but it also appears that many of these patients with resistant hypertension have an overexpression of the sympathetic nervous system, and that may be driving some of the resistance to pharmacologic therapy that we see. Certainly, some of that may be treated with a pharmacologic approach. We have peripheral alpha blockers, beta blockers, centrally acting agents that can affect the sympathetic nervous system. But there's also some interest in potentially looking at device therapy that targets the sympathetic nervous system. And there are a couple of different approaches that have been studied. One of them is renal denervation therapy. And as I'm sure many of you in the audience are aware, there was some previous attempts to demonstrate benefits with renal denervation in patients with resistant hypertension that were not successful. But we have retooled some of those interventions. And importantly, I think we have learned a lot about how to design an appropriate clinical trial in patients with resistant hypertension. And there are a couple of ongoing studies of renal denervation in patients with resistant hypertension. And we have also seen some studies in patients with more mild to moderate hypertension that have been done in parallel. So I do think this is something to keep an eye on. And there are other approaches as well to device therapy for patients with resistant hypertension. So these are my take-home messages. Essentially, it's a recapitulation of that treatment algorithm. First step, of course, is confirming treatment resistant using the updated definition from the guidelines, excluding pseudo-resistance, including poor adherence and white coat resistance, identifying contributing lifestyle factors, discontinue and minimize contributing lifestyle factors, as I mentioned, interfering substances, screen for secondary cause, and then rationalizing pharmacologic therapy, that good ACD therapy as your foundation. Consider changing your thiazide diuretic to chlorthalidone, or even a loop diuretic if you have chronic kidney disease. Next step, likely in adding a mineralocorticoid receptor antagonist, and then some other recommendations that you see outlined on this slide. So with that, I will conclude. I want to thank you very much for your attention, and I will take the opportunity to invite our next speaker.
Ladies and gentlemen, Professor Vinaya Simha has arrived. I'll be introducing him sharply at 10 o'clock. That's as we have announced, as the rest of the audience come. Now we'll continue with the second webcast from the National Lipid Association, which is about some challenging, unusual, common manifestations of unusual dyslipidemias. So we will start the second webcast. By the time I understand this is a case-based discussion, exactly at 10, we will introduce our international guest speaker, and rest of the program will follow. So give me a couple of minutes to start the next webcast. Thank you. Uncommon dyslipidemias with common presentations from Professor James Underberg from New York.
Who's a faculty member at NYU, where he also directs the Bellevue Lipid Clinic. Everyone knows Jamie. Jamie, I would suggest using the lavalier. I know Jamie for a long time. He was actually my intern at Bellevue. And the great thing about being my intern at Bellevue, he still looks up to me like I have something to say and I'm still important. So it's good that he looks that way. But Jamie is going to be is president-elect of the NLA. He's been on every NLA committee of substance, recently NLA Part 2. You're going to hear a lot more about Jamie, and I'll just conclude, he is the triple threat. Great clinician, great educator, and he's from New York.
All right, thank you very much. It's great to be up here with Terry, who, if it weren't for him, I wouldn't be here, because I got assigned to him as an intern, and I'm with this wacky guy who's checking everyone's cholesterol. And they're like, oh, well, just give Underberg to him. Follow him around. And he kept telling me to check stool guaiacs on everyone every day. Bellevue, you do that. So anyway, the topic I was given was uncommon dyslipidemias with common presentations. And there is going to be some overlap in what I'm going to say and what you heard from Anne. It's almost impossible to talk about this without talking about...
Who's a faculty member at NYU, where he also directs the Bellevue Lipid Clinic. Everyone knows Jamie. Jamie, I would suggest using the lavalier.
And if you think about triglyceride disorders, and if you think about lipid disorders in general, if you go back to the Friedrichsen criteria, 1, 2A, 2B, 3, 4, and 5, everything except 2A includes triglycerides. So it's almost impossible to talk about lipid disorders without talking about triglycerides. So when I get to the areas where there are overlap, it's there for a reason, but I'll go over it fairly quickly because you heard such a wonderful overview from Anne a little earlier. So these are my disclosures. And this is the outline. I've got a case study. And if you think about triglyceride disorders, and if you think about lipid disorders in general, if you go back to the Friedrichsen criteria, 1, 2A, 2B, 3, 4, and 5, everything except 2A includes triglycerides. So it's almost impossible to talk about lipid disorders without talking about triglycerides. So when I get to the areas where there are overlap, it's there for a reason, but I'll go over it fairly quickly because you heard such a wonderful overview from Anne a little earlier. So these are my disclosures. And this is the outline. I've got a case study. I'd like to review 4 topics that I think are oft overlooked and could be confused and often misunderstood: lysosomal acid lipase deficiency, familial chylomicronemia syndrome, familial combined hypercholesterolemia, and then lipodystrophy. So this is one of my favorite phrases. I always use it with our house staff. The eye cannot see what the mind does not know. Every time I ask our trainees, well, what's the differential diagnosis? They say, oh, we don't need to know it anymore. We can look it up. Well, if you don't know what to look up, you don't know what you're looking for. At least that's the way I always think about it. So certainly when we see common things all the time, you start to assume that everything that you're looking at is a common cause. And if you do that, you will be mistaken, you will be misled, and especially as experts in the field of clinical lipidology, you don't want to miss the uncommon disorders because that's why these people are being referred to us. So here's a case. I'm going to go through it quickly. I think this is a case that every one of us has seen over and over and over again. It's a 40-year-old male. He's overweight, body mass index of 26 with mild dyslipidemia. He's been treated with atorvastatin, 20 milligrams, and aggressive diet and lifestyle interventions. Total cholesterol, 210. HDL is low at 38. Triglycerides, 200. And an LDL cholesterol of 132. He's already been told of mild fatty liver that was found on an abdominal sonogram. And in the setting of mild transaminases, most people felt that was reasonable and appropriate. He gets lost to follow-up for 7 years. I love that phrase, just wandering around New York, aimlessly looking for a lipidologist, right? Returns at age 47, off statin. No surprise, we all see that also, right? And he was actually told to stop statin at one point during this 7-year hiatus in the desert because of increasing liver function tests. His total cholesterol is 250. HDL is now low at 25. Triglycerides 180, not really any worse, and in fact a little better than before. And the LDL cholesterol is 189. Now when our house staff present cases to me like this, I ask what the diagnosis is, and their answer is mixed dyslipidemia. That's like when I was training, someone say the patient's very sick, they have multiple medical problems. Remember that one? So mixed dyslipidemia, which drives me nuts. Repeat liver function tests, the AST, the ALT are up a bit now. Bilirubin's normal and the GGT is elevated. So we spent a lot of time trying to convince this guy that he must be drinking, even though he tells us that he isn't drinking. Body mass index is 27. A repeat sonogram shows that the fatty liver seems to have progressed, and now he's got a little hepatosplenomegaly. Liver biopsy, because he goes to see a hepatologist, shows that he's got a mixed macro and microvesicular pattern. Now, I think we see patients like this all the time. And I think after all of this, most people would still say that this person has fatty liver, he's dyslipidemic, he's insulin resistant, right? Maybe he needs some ApoC3 inhibitor, right? And the bottom line is that we just move on. We tell him that he's got to exercise more, lose weight, et cetera. But I would tell you there are lots of things that could also be considered in a patient like this. So you heard a wonderful overview of the common causes of hypertriglyceridemia. I just want to point out that in the middle there is hepatic steatosis or steatohepatitis. These are often seen together. PCOS is often seen in this setting, right? Familial hypertriglyceridemia and familial combined. I wanted to just show you this so to remind you that these less common conditions are often listed in these common compendia. Medications often, right? Common things that we use, so you always want to rule that out. Oral estrogens, protease inhibitors, even bile acid sequestrants in some cases. So what can I tell you about lysosomal acid lipase deficiency? I'm going to go through these conditions just to remind you they exist, you need to know about them, and there's certainly something that you should consider if something doesn't make sense. The lysosomal acid lipase deficiency is exactly what it sounds like. It's a lysosomal storage disorder, and it's a deficiency of the enzyme lysosomal acid lipase. Historically, it was originally described by Dr. Moshe Wolman as Wolman's disease. Dr. Wolman was a doctor in the British Army. His other famous kind of notoriety was that he was involved in escorting Haile Selassie back to Ethiopia after the war. But about the same time that he described classic Wolman's disease in infants, kind of the father of modern-day lipidology, Donald Friedrichsen, also described something that he called cholesterol ester storage disease, which turns out to be two ends of a spectrum of the same abnormality, which is a deficiency in the enzyme lysosomal acid lipase, which can present with a myriad of abnormalities because the enzyme is found in a variety of different organ systems in the body, in the gastrointestinal tract, in the spleen, in the liver, in the adrenal gland, in the macrophages, etc. So again, cholesterol ester storage disease and lysosomal acid lipase are one and the same. It's an autosomal recessive condition, so it's not common. I would describe it as uncommon, but I always hesitate to say rare anymore because we really never know how rare or uncommon these things are, right? If you thought homozygous FH was rare, well, it was 1 in a million. Well, now it's 1 in 300 or 250,000. So maybe it's uncommon, but not rare. This is a multisystemic disorder. Unexplained elevations of, and if you think about triglyceride disorders, and if you think about lipid disorders in general, if you go back to the Friedrichsen criteria, 1, 2A, 2B, 3, 4, and 5, everything except 2A includes triglycerides. So it's almost impossible to talk about lipid disorders without talking about triglycerides. So when I get to the areas where there are overlap, it's there for a reason, but I'll go over it fairly quickly because you heard such a wonderful overview from Anne a little earlier. So these are my disclosures. And this is the outline. I've got a case study of transaminases with high LDLs, but rather low HDL cholesterol and only moderately elevated triglycerides. So often this is the thing that we talk about when we call people mixed dyslipidemics, right? There's someone who has typical dyslipoproteinemia of metabolic syndrome, but that LDL, which should be low or normal, is actually much higher in the inherited LDL cholesterol range, LDL receptor disorder range. So many of these patients are diagnosed in childhood in the most severe presentation, the typical hepatosplenomegaly and the failure to thrive and the decline into liver failure at an early age. But there are adults that don't present until either adolescence or even later in life. And in many of these patients, they may be missed completely. And they go on to develop atherosclerosis or liver failure that's called cryptogenic, and they die. So what's the etiology here? Lysosomal acid lipase is the enzyme involved in taking esterified cholesterol and triglycerides and breaking them down to free cholesterol and glycerol and free fatty acids in the lysosome late endosome. Ultimately, what happens is then free cholesterol and triglycerides leave the lysosome, get into the extracellular space, and tell the liver that everything's okay. We've got enough cholesterol, and the cholesterol and synthesis is shut down, and production of the LDL receptor is shut down. So if you don't have enough lysosomal acid lipase, what happens? You don't have enough lysosomal acid lipase, esterified cholesterol and triglycerides don't get broken down. No free cholesterol and free fatty acids make it into the hepatocyte cytosol. And what happens is the liver cell doesn't think it has enough cholesterol. It upregulates production, and it upregulates expression of the LDL receptor. Well, production leads to increased lipogenesis and generation of VLDL, which leaves the liver. The upregulation of the LDL receptor leads to further internalization of LDL and VLDL particles that end up in the lysosome and they never leave. Hence the increasing lysosomal accumulation of fat and triglycerides and cholesterol that leads to the liver disease and the splenomegaly and the splenic disease. The issue here, interestingly enough, is kind of confusing because if you give a patient like this a drug that upregulates the LDL receptor, you'll probably lower their cholesterol. And some people believe this is a good thing to do for these patients. But there are other people who believe that by doing that, you are inherently worsening the lysosomal storage issue by bringing more cholesterol in through the LDL receptor. And it's unclear whether one is better than the other and which one you should target. But either way, you're potentially either lowering the cholesterol or potentially making the liver disease worse. Now, these patients also have very low HDL cholesterol levels, lower than you would expect based on their triglycerides. Why? Well, it's interesting. One of the ways the cholesterol gets out of the liver is kind of a backdoor egress via the ABCA1 transporter. And so it turns out that the liver shuts down the gene that codes for the ABCA1 transporter because the liver doesn't want cholesterol leaving through the back door. And so what happens is HDL goes down, not because the triglycerides go up a bit, and certainly that might account for some of it, but the majority of the low HDL is because of this impact on the ABCA1 transporter. So how common is lysosomal acid lipase deficiency? Anywhere between 1 in 43,000 to maybe 1 in 300,000. It's really hard to tell because up until recently, we haven't had a lot of easy ways to check for it. Now you can check enzyme activity level. You look at LDL cholesterol levels, they're in the FH range, 2 to 300. HDL cholesterols are low. And again, triglycerides are moderately elevated in the 150 to 200 range. So again, these are the HDL cholesterol levels, and they tend to be low. So how do you deal with something like this? Well, now actually we have a recombinant infusion of the enzyme itself. You can give it to these patients, and you can actually reverse all of the processes that are associated with the condition. But again, fatty liver, mixed dyslipidemia, LFTs that get worse on a statin, that's seen every day in everyone's practice. And when you see that, and it just doesn't make sense, stop and think and say, gee, maybe I should be looking at something else. So what about severe hypertriglyceridemia? Well, you heard a great presentation from Anne about this, and I'm not going to go into it in any detail, but to remind you that, again, you can be confused even by the causes here. So this is a patient that we saw for a while in our clinic in Bellevue, and this is a woman who actually came to us with a history of lupus and recurrent pancreatitis. And every time her diet would be inappropriate, no matter what number of medications we're on, she'd call us up and she'd say, my stomach hurts, I'm on my way to the emergency room with pancreatitis. And we assumed that her pancreatitis was associated with her lupus and all her lupus medications. And every time she had a lupus flare, she'd take all of these medications that would worsen her triglycerides and she'd get pancreatitis. But then we decided to actually look at the disease activity and relate it to her pancreatitis, and it turns out they went in opposite directions. And every time she was on no meds and her lupus was fine, that's when she had pancreatitis. Well, it's actually when she was feeling better and she was eating more fatty food. And it turns out, we said, oh, she must have some of these disorders that Anne talked about. She probably has lipoprotein lipase deficiency. And again, Anne, in a very nice overview of all of the different genes can affect triglyceride metabolism. There are primary causes, secondary causes, and then, of course, the more common scenario is an underlying genetic cause with a superimposed secondary insult, like a partial lipoprotein lipase deficiency, and then you go out and drink and start taking birth control pills, right? And that'll raise your triglycerides very nicely. So again, monogenic and polygenic forms contribute to the condition. These are the major genes that are affected: lipoprotein lipase, ApoC2, GPI-HBP1, which Anne so succinctly pronounced. You have to be a lipidologist and say that 5 times fast. It's like icosapentaenoic acid. ApoA5, and then lipase maturation factor 1, which is an enzyme involved in activating some of the lipases like lipoprotein lipase and hepatic lipase. So it turned out that our patient actually had a deficiency in lipase maturation factor 1, not typical lipoprotein lipase deficiency, which is probably why she didn't present early in life. And it may have been contributed to, indeed, at some extent, by her lupus, because we know that lupus is also associated with hypertriglyceridemia. So again, I show this just to tell you that even within the context of what looks like typical lipoprotein lipase deficiency, there are these other causes that can actually be associated with more common elevated triglyceride syndromes, but often from more uncommon etiology. Now, why do we treat hypertriglyceridemia? Because we want to prevent pancreatitis. And interestingly enough, we still don't have any data, other than maybe with some of the gene therapy, that suggests if you intervene with the medication per se, you reduce pancreatitis risk. But we know if you treat hypertriglyceridemia, it was shown very eloquently by Dr. Brunzell way back in the 1980s. And this was reprinted in JCL in 2012. Shows that if you target hypertriglyceridemia through a variety of different mechanisms, and you eliminate chylomicronemia, you dramatically reduce admissions for pancreatitis from 105 per year here to 1.8. So let me just move on here. This proposed relationship between hypertriglyceridemia and pancreatitis is impacted by a variety of other issues: secondary causes, familial causes, and then obviously other underlying causes of pancreatitis. And so these are our emerging therapies for chylomicronemia. There are a whole host. You've heard about some today already. I'll tell you that lomidopide is probably not a good thing to use to treat hypertriglyceridemia, because the liver disease that you get from that probably isn't worth it. And it's obviously not approved for that either. But we do have a host of other things that you might consider using to manage these patients. So what about familial combined hypercholesterolemia? Ann mentioned that also. This is the type 2B that we often think about. It's been described as a common familial disorder, multiple lipoprotein phenotypes, genetic basis for familial combined, and the mode of inheritance, again, still remains controversial. You can't make the diagnosis without a family history, right? But again, how you inherit it is still unclear, probably because of the polygenic nature of it. That's why we're not sure. It's characterized by several phenotypes, but high total cholesterol, increased triglycerides, decreased HDL cholesterol, increased ApoB in the presence of small, dense LDL particles. Increased production of VLDL with or without impaired clearance of triglyceride-rich lipoproteins in most of these patients, and then ApoB being increased out of proportion to the LDL cholesterol is often what we see. There are a variety of pathways involved in the pathogenesis of familial combined. Again, often this is seen associated with insulin resistance, and the link and the cause and the effect here is still unclear. In familial combined, it's anticipated that there is a disbalance between the de novo lipogenesis and beta oxidation in favor of the former, resulting in hepatic fat accumulation and VLDL overproduction. Gee, it sounds just like that first patient I mentioned again. You're starting to see how there are these big Venn diagrams, and they're all intersecting in this kind of globus of a patient that's wandering into our office every day. And when we think about the genetics of familial combined, it's all over the place, right? There's a variety of different genes that can impact all of the things I've been talking about, though. Although I will tell you, I'm fascinated by the role of ApoC3 in this patient. And again, that might be some sort of a link between many of the commonalities. How do you diagnose it? I'll give you two great ways to diagnose this. One is a wonderful nomogram that was published a while ago now. It's in circulation, and it's a great way to look at these patients. But there's also an app for that. It's a great app called an ApoB app. Alan Snyderman, I think, was one of the people involved in this. And it's actually a wonderful way to make the diagnosis of familial combined. And again, when you think about potentially the way to treat these patients, one thing that comes to mind is, again, because of the potential of SREBP2 to be kind of a central focus in how these patients actually develop this condition. And because of what we understand of what happens when you give patients statins and how they increase PCSK9 levels, the potential role of statins plus PCSK9 inhibitors in patients with familial combined hypercholesterolemia is certainly intriguing. And finally, I want to end with lipodystrophy. Lipodystrophy is a complex and uncommon disorder that can be described as congenital, acquired, general, or partial, right? So you can mix and match any of those. The first thing I'll tell you is that if you have a patient in your exam room and you don't make them take off their pants or their shirt, you're not going to be able to make this diagnosis. You have to actually examine your patients. And so it always gets me nuts when, I go into the exam room, the students have seen a patient and clear that the clothes have never come off the body. There's no way you can make this diagnosis if you don't examine them, never mind looking in the eyes or feeling their Achilles. So lipodystrophy is an uncommon heterogeneous group of syndromes, all right? This group of syndromes that can be either complete or partial, and again, can be congenital or acquired. Often seen with metabolic derangements, insulin resistance, diabetes, hepatic steatosis, steatohepatitis, and dyslipidemia. It can lead to acute pancreatitis, just like FCS. Hepatic cirrhosis and premature cardiovascular disease. Additional manifestations, PCOS, acanthosis nigrans. They can develop insulin resistance, eruptive xanthomas, non-alcoholic fatty liver disease, and progressive liver disease. So the key endocrine abnormalities here in these patients, they have an absence of adipose tissue, primarily subcutaneous. The levels of adipocyte hormones are altered with low leptin levels and reduced adiponectin levels. This is just a list for your edification. I'm not going to go through it, of the congenital lipodystrophies that are either general or partial. The next year, I have a classification of the acquired lipodystrophies. And if you look at some of them, they're things we know, like HIV, acquired partial, which are often associated with autoimmune disorders, etc. And there are some that happen for idiopathic or unknown reasons. What's the metabolic impact of lipodystrophy? Well, it's really something that focuses on a variety of different factors of our entire kind of metabolic apparatus. And so basically, if you understand that these patients have reduced levels of leptin and reduced levels of adiponectin, that leads to increased food intake, right? the increased production of chylomicrons in the delivery of substrate to the liver, but also because of low adiponectin levels and the impact on insulin, you see increased lipogenesis and abnormalities in fat storage, especially peripherally. Increased free fatty acids lead to the insulin resistance, the cardiometabolic abnormalities that we typically see in metabolic syndrome and even pre-diabetes. So when it comes to treatment issues for these patients, reduced triglycerides and cardiovascular risk, insulin resistance, diabetes, fatty liver and progression to liver disease. So how do we manage them? Well, restriction of total fat intake, omega-3s, fibrates, statins, insulin sensitizers have all been tried. And now we finally have available to us recombinant leptin replacement. And again, this is not something that's going to be for everyone, but the clinical action of this, it's called metroleptin. You can give it to adipose-deficient lipodistrict patients. It actually increases leptin levels and reverses the abnormalities, very much like I talked to you about sebelase alpha in the patients who have lysosomal acid lipase deficiency. The clinical effects of this intervention, there's one study here in 55 patients, 36 who had generalized and 19 who had partial lipodystrophy. Metroleptin significantly improved glycemic variables, triglycerides, liver enzymes, and demonstrated a durability of response throughout a 3-year treatment period. Approved for treatment of complications related to leptin deficiency. No established data for partial lipodystrophy, HIV lipodystrophy, or someone who simply has fatty liver disease. Or certainly, again, the intersection of all of this is intriguing. So the summary and takeaway messages, again, the presentation of elevated triglycerides with or without pancreatitis, fatty liver and other cardiometabolic risk factors is a common presentation. Patients have underlying inherited disorders, not with atypical phenotypes. Secondary causes can often exacerbate underlying conditions, and less common disorders with common presentations can now be treated. So thank you very much for your time and attention. That was great.
Thank you. You heard the two broadcasts from the National Lipid Association. You know, such valuable resources are made available free of cost to all over the world. And now we will move on to the formal presentation. Okay. I take this opportunity to welcome Dr. Vinaya Simha. Many of you or most of you know about him, but let me do the introductory job in brief. Vinaya Simha is God's gift to the Samatvam Jnana Sanjeevini. I remember introducing him in Hotel Ashoka for a CME. That night I prepared. Vinaya is humility, Simha is lion. So I admire his parents, lion of humility. Okay, lions being humble or not known, lion of humility. The second one, I think I Googled something from Chanakya at the time, Vidya Dadati Vinayam. So humility gives education. And I don't have the full shloka today. Just to tell, he's a, why don't you do that? Okay, one rule here, kindly maintain perfect silence. We have been doing webcasts. Today is my 5-year dream come true, that when we did webcasts, we could hear the speaker, but we could not hear all of you. Now, if you want to speak, there is a hand microphone. Okay, Madhumati, it is your job. So anybody wants to speak, you have to speak to the hand microphone, because it is being broadcasted all over the world. It's open to YouTube. So don't speak without that, like your NDTV Barkha, that somebody will give you that roving mic. Okay, that is number one. and we have people from different parts. Nanjangud doctor has come, Dr. Rajiv, and I also should thank two people, our IT people, the hardware man, Mahesh, and Soumya, the software lady. Come to the front. Okay, they work very hard. Okay, I don't. Okay, go there. These two people, the hardware and the software. Okay, go back to your seats. Madhumati, you have to take charge of the thing, because one advantage is this is on a Google Hangout on the air we are doing, but today we hope the electricity doesn't give us a heart. We need uninterrupted power supply here. I need an uninterrupted power supply at the internet server. Yeah, if I have this room, then the YouTube will get cut. It is being live broadcasted, and Vinaya saw the taste of it. One more advantage is at the end of the session, everything will be archived automatically. So people who didn't come can listen to it. No extra involved. Thanks to the likes of Sundar Pichai. Now, okay, no, please, anybody talk to the phone. Let me complete the customary thing. Dr. Vinaya Simha is a Bangalore boy, somewhere from Rajajinagar, Basveshwar Nagar side. He was a graduate from Kasturba Medical College. Just give me 1 minute. I have everything. Okay, just give me a little bit time. Okay, MBBS from Kasturba Medical College, internship St. Martha's Hospital, MD Physiology from my alma mater, All India Institute of Medical Sciences, then a resident internal medicine, Interfaith Medical Center, New York, fellow division of endocrinology metabolism at University Texas Southwestern Medical Center, where he worked with one of my juniors in All India Institute, Dr. Abhimanyu Garg, a world leader in this field. Many of you do not know, I might have played Abhimanyu Garg was junior to me, and I might have played a role in pushing him to lipid biology. When I was in the beta cell, he was in Alabama, Abhimanyu Garg, doing his fellowship. He came and told me which field I have to choose. I told him, don't choose PCOS, don't choose rare things, choose something which will make an impact on society. And since beta cell was taken over already, he was working, we came up an idea that lipid biology and vascular biology, atherothrombosis. Okay, he was one night in my studio in Boston. Okay, and nice to see. In fact, yesterday night, I did some Googling. Today, they will present few cases, including one case which Vinaya had diagnosed here in the same hall. It's a partial lipodystrophy. He saw and he said, it looks like a progeroid syndrome. And he wanted genetic test, but we have delayed by 3-4 years. Yesterday I read their paper, middle of night, the first series published by Abhimanyu Garg, and where he is one of the co-authors, that I think about 8 patients. And then I read a new paper in 2008 by Hussain et al. Dr. Saab talked about it. They presented the date. At that time, there were 31 patients and they had 8. That is 2014. Vinaya is one of the author. And I read a latest paper by Hussain from the Abhimanyu group itself, where they have reported 9 + 2 patients, 9 new and 2 old, with a specific. I remember Vinaya telling here it is most likely a laminin mutation. I had forgotten about it. But today when I read the case we are presented, most likely will be his diagnosis right, because the young lady has developed cardiomyopathy. Okay, cataract, etc. At that time she didn't have. We thought it was due to chemotherapy to cancer. So whole night it was Vinaya and Abhimanyu. And so that is the Texas Medical Center. Then he moved on to Mayo Clinic, where he is one of the senior faculty, and American Board, Internal Medicine, Endocrinology, etc. Indians are supposed to be very good teachers because of patience. Even when I was in Harvard, a lot of the Indian people would get the Best Teacher Award. And likewise, in 2011, Vinaya was awarded the Best Teaching Faculty in Internal Medicine. at the University of Texas Medical Center. A little before, Daniel W. Foster Award, one of the famous people in metabolism, for excellence in teaching in a division of endocrinology. So it goes on, a teacher par excellence. Now, what I would do is, I would uh, give the mic to Dr. Sharada. You can get the proceedings. I need 2 minutes to load Dr. Vinaya's slides. We will try to go exactly as per this. The first lecture is on the principles of lipid treatment and novel lipid therapies. And in between, we have cases. We have few additional cases. I want the case presenters to do their cases rather fast. You have a world leader. We have most of you have seen this. We are harassing him with 4 presentations. Somebody told me, Jnana Dahi, a thirst for knowledge. And one more thing, this is for Vinaya. Somebody taught me a famous quotation from Samson Wright about 6 months ago. Let me repeat it. Samson Wright was a physician, cardiologist, FRCP, who became a teaching physiologist. So he had a love for teaching, combining clinical medicine. He is the man who wrote the textbook. He talked about teachers and students. More than the calf wishes to suck, the cow yearns to suckle. More than the calf wishes to suck, the cow yearns to suckle. That means teacher is much more interested in sharing his knowledge than the students where the calf would suckle. This applies very aptly to Vinaya. It is a routine for us. And not only that, we take it for granted that his home in Rochester is our home, our uncle's home. He has hosted so many people. Chandrika, Sumathi, and even we have dumped our patience on him. He has kept for, I can only say, pray for his welfare of he and his family. So as I load his slides, this is a technique called screen sharing. Okay, it's okay. Hope Mahesh, put the generator on. This may work. If the internet gets cut, we have to restart the thing again. I need UPS. Allu UPS hakidiyappa. And today it has to run smooth. Now, Sharada, pick up the phone. Just say your comments. And by the time, I load the presentations. She wants Vidya Dadati Vinayam Shloka. Okay. Yes, every presentation.
You get the because of your ability to earn money. The money you have. And after you have received the money,
Please make sure you turn on. Just give me 1 second. 1 second. First one is. We turn the lights on. When I tell you, Okay, fortunately, we were able to restore the internet, not our mistake. So the broadcast continues. 1 second, turn off the light. One more thing, we have a control room there inside where they are monitoring the sound, etc. Amma, the sound is coming okay there? You can hear Vinaya's sound? Okay, over to you, Vinaya.
So the first one is to talk something about more general terms about the principles of lipid treatment. Okay? So again, as I said, so do I put the slides or how do I?
You have the.
Can I use this?
Can you move this also? Yeah.
Yeah. So that's fine. That's good.
Okay.
This is the point.
ಇಲ್ಲಿ ಇದಾಕಿದ್ಯಪ್ಪ ಮೂವ್ಮೆಂಟ್ ಇದೆಯಾ ಎಲ್ಲ ಹಾಕಿದ್ಯಾ ಇಲ್ಲಿ ಹಿಂದೆ ಹಾಕಿದ್ಯಾ ಓಕೆ ವೆರಿ ಗುಡ್
Okay. All right. So this presentation has about 90 slides. Okay. So clearly, I mean, I don't want to do 90 slides in 45 minutes. And the whole concept of why do we do lipid lowering therapy really is summed in this one slide. Okay. So if there's only one thing we need to understand the whole day, it is just this. Okay. So we do lipid lowering therapy simply to reduce cardiovascular risk. And much of all this smoke about lipid lowering therapy. Not it. Okay. Is this better? Okay, good.
Mahesh, check that volume of the webcast. If need be, you can increase it. You should be monitoring there also. Thank you. Go ahead.
So we spend a lot of time talking about, which drug to treat and then what, what level, should it be LDL of 50, 70, 90, LDL, non-HDL, all of these things, I think we're actually getting lost in all these ephemerals. The real thing is, are we reducing cardiovascular risk or not? And that's the most important. There is no such thing as a sudden heart attack. This is a slow disease. This affords us a lot of opportunity. And if anything should keep us up at night, it is this, that all our patients are actually cooking up to get this sudden heart attack, and what are we doing to prevent this? There is that, and there is also the small matter of pancreatitis. So I think in the afternoon, we'll get back to pancreatitis. Okay? This is why we treat them, reduce pancreatitis to reduce heart attack. And what is the best way of doing this? Again, we spend all our time talking about drugs, but really, for the vast majority of patients, it's a lifestyle disease. So it is all about diet, exercise, and other risk factor modifications. So that's much more important than drug therapy. And indeed, these are all the lifestyle recommendations from the 2013 ACC/AHA guidelines. So the most important thing, of course, they start with diet. And so diet low in saturated fat, trans fat, and sodium. There is this other thing. So there's no mention of dietary cholesterol now. And there is, I think, a lot of controversy and confusion about this. So there's a difference between dietary cholesterol and dietary. Okay. So, I actually have, now it's all about these WhatsApp groups. And then, so I get these WhatsApp things from other people, from my other family and friends and relatives saying, now in America, they say cholesterol is not important for heart disease. Okay. So that's not true. Cholesterol is still quite bad. What is not probably an important determinant is dietary cholesterol. Okay, so dietary cholesterol, that is pure cholesterol, and then we can talk about this. So there's a lot of interesting data showing that our body is able to regulate how much cholesterol it actually absorbs and utilizes. So even though we eat a lot of cholesterol, we don't necessarily absorb all that cholesterol. But on the other hand, again, that is not to mean that diet does not have an important role. Saturated fat is still quite bad. Okay, so in fact, in the it was the Times, I think. So Times actually had a blow-up article saying eat more butter. Okay, after these studies came out, which is completely wrong. Okay, so saturated fat is still quite bad. It is just the dietary cholesterol is probably not an important thing. Again, these things need to be studied, I think, in the Indian context, because those studies were done where they replaced, like say, lard or one of those beef tallow with polyunsaturated fat and then showed benefits. Okay, So I don't know how much saturated fat there is in the Indian diet, and most of it is medium chain fatty acids. So, coconut oil and other things. So they're probably not as atherogenic, and we can't just be blindly following these things. So we really need more data on this. But nonetheless, saturated fat is probably still bad, and especially the long chain fats. Trans fat is clearly bad, and then most people are, of course, avoiding fat. And then, there's emphasis on vegetables, fruits, whole grain, and so on. Restrict sweets, sugar-sweetened beverages, regular aerobic exercise, avoid smoking, and maintain healthy body weight. Okay? So this should be the cornerstone of lipid-lowering therapy and of a healthy lifestyle and cardiovascular risk. But of course, what we really spend most of our time and the rest of the day, so now that I'm done with what is the politically correct thing to say, we can deal with what we really are going to talk about today, and that is drugs, okay? So drug therapy for lipid-lowering. Again, I won't go into all the details, but just a few things that I think are pertinent for the way the field is moving today. Okay, so all of us understand that the goal is cardiovascular risk reduction, but the controversy is how do we tailor therapy for this? Is it by using an appropriate statin dose? Is it sufficient if we just give everybody moderate or high intensity statin therapy, or should we target an appropriate LDL reduction? Okay? Should we talk about 30% reduction, 50% reduction, or should it be an LDL target? Like how we used to do in the past. So this person, he should have an LDL target of 50, 70, 90. So what is the right way of doing this? Or are they all different? Or are they all complementary? Okay? The reason why I'm talking about all this is now the buzz around is that we are soon going to get the ATP, whatever, 5 or 4 or it's probably going to be called the 5 because there was ATP 4 and then there was, well, actually, so this was the ATP. So if you remember, so the National Cholesterol Education Program, which was formulated by the National Heart and Lung and Blood Institute, so they have actually rendered human service to this field. So they constituted the adult treatment panel, the ATP, and so a bunch of experts, they actually looked at all the available data at that time and formulated guidelines on how to do lipid-lowering medications. And so we have had successive iterations of this. We have had the ATP 1, 2, 3. And then when they last left in 2006, so we had the ATP 3, and then there was an ACC-AHA update, and it looked something like this at that time, okay? So we had people, we stratified them based on their risk, and like whether they were very high risk or moderate high risk and so on. And for each of these stratum, we had particular LDL cholesterol goals. Okay? And this is how we treated them. So we wanted to get a person at this level of risk with this level of LDL cholesterol. And there was also a threshold therapy at which to start drug therapy. So this is how we were. But then there was this paradigm shift in 2013 when the ACC-AHA came out with what was the ATP4, but then, it was ceded to them. And then the ACC-AHA came out and said, oh, no, there is absolutely no data supporting this treatment to a goal LDL. All the data is on using appropriate statin intensity. And so therefore they said, we are not talking about cholesterol lowering. We're only talking about statin therapy. It almost became very statin centric. And that's what we now have. So they recognize these 4 groups of patients who benefit from statin therapy. You know all this, so I don't need to spend too much time on this. So these are the 4 groups. People who have already had cardiovascular disease, so secondary prevention in them. And then, of course, primary prevention in those of very high LDL cholesterol. These are people with FH, presumably. Then in people with diabetes, and primary prevention in those who are not in any one of these groups, but who have an estimated risk of over 7.5%. And I think previous years we went into some of all these controversies that surround this. But by and large, most people, this is the playbook by which we go now. Okay? So we recognize, and of course it doesn't end there. There are all of these other groups also who probably benefit from statin therapy. So people with lesser degree of hypercholesterolemia, but where there is some evidence of genetic dyslipidemia, people with family history of premature CHD, high CRP, evidence of subclinical atherosclerosis, either by a high CAC score or all of this. So, this is what we call extreme vetting, okay? The days of Trump, okay? So everything is about extreme. So this almost leaves nobody, okay? So there was this. So when these guidelines actually came out, so the New York Times had this very nice cartoon. So it said, So new guidelines for statin therapy. Step 1, check your pulse. Step 2, if you have one, take a statin. Okay. So it was like that. So they had a, so it was almost like this. So this virtually you would treat everybody. But that's not really true. Okay. So this is probably one of the first guidelines where they even mention those who should not get routine initiation of statin therapy. Patients on hemodialysis, people with advanced heart failure. And they were not sure about the role of primary prevention in people over 75. Okay. Now, obviously, there's a lot of controversy about all of these things, but nonetheless, we are still working on these things. But then, now I think the way the, and anyway, once you identify them, so there is this particular intensity therapy, and this is what we'll leave those things. I think you know this. So, I think the interesting thing that's happening now is I think there is a shift back, probably to getting back to LDL cholesterol goals. Okay. So the grapevine is that Dr. Scott Grundy is now again, I mean, that is known. So Dr. Scott Grundy is back to heading the ATP, and so they think that perhaps this is what will happen. Now, one way of knowing whether what will happen is the kind of publications that are coming out. And this, I think, is a very interesting set of analysis, okay, that's happening. So these are what are called waterfall plots. Okay? So usually the it shows us the response of the whole group to a particular drug. Okay? So these are the 1,000 patients who got 10,000, what, a few thousand patients who got pravastatin. And so all of them get the same 40 milligrams of pravastatin, but what you see is the response is not uniform. So there are some who get a very robust response, almost 50%. And then it goes on like a waterfall. Okay? So that's what it is. And the same thing with everything. Okay? This was statins. This is like monsoon now, you know. Every day I see